So in this next 8 minutes, what I'm going to show is share my experience of last 3 years consecutive cases of primary rheumatogenic retinal detachments and what our experience is compared to what Nitin and Nishikant and everyone said. So primarily I'm going to talk on tamponade. Tamponade means plug. So in vitrectomy surgery, tamponade essentially we mean internal tamponade, that is gas or oil. I'm not going to discuss about heavy silicone oil because I don't have any personal experience. And in my experience, what gas I'm using is most often, almost always C3F8 and 5000 centistroke silicone oil. So what data I'll be discussing is on that. Now, all we know, all of us know that sulfur hexafluoride would remain in eye for a week or 2 weeks maximum, and the interfacial tension is 70. I use C3F8 primarily because it remains in eye for 6 to 8 weeks, and I believe that proliferative vitreoretinopathy, the disease process is active for probably 2 months. So this is the best bet we have in combating PVR and supporting the break. And again, the interfacial tension is 70. Unlike that, silicone oil interfacial tension is only 35. So as far as tamponading effect is concerned, the silicone oil is half the of gas. So probably gas is a superior tamponade compared to oil. That is what I would show in my talk. 5000 centistroke I usually use because it has less emulsification compared to 1000 centistroke. Heavy silicone oils are not available in country and they are quite expensive, so we have limited experience. The advantage of gas, as I told you, has higher buoyancy and tamponade effect, whereas oil has longer tamponade. It remains in the eye till you don't remove it. The another advantage of oil is that air travel is possible, and third advantage is that vision is relatively better. If you operate a patient with 6/6 vision and do vitrectomy with gas, and probably for a month he may not have more than counting finger vision, so he may be upset. So, but the disadvantages of oil is emulsification, glaucoma, and band-shaped keratopathy. And even if everything goes well, you need to remove oil by second surgery. So I use gas practically in most of the cases. And when position is problematic, you can use oil. Now, these are our results of 3 years. We had 100 patients, consecutive patients, in which gas was used in 84 patients and oil was used only in 16 patients. We had success rate of 80% with gas, whereas success rate was 62% with oil. So we had higher success rate with gas, and I believe this is because of the better tamponade effect of gas compared to oil. Now, everyone discussed about inferior breaks and buckle and those things. Now, this what has been our experience, I'll share with you. Now, of the patients who were attached 76, 22% had inferior breaks, but still were attached with vitrectomy and tamponade. And of the 24 patients who were detached, so 24% who were detached, only 21% were because of the inferior breaks. So I feel inferior breaks, gas or vitrectomy and oil is a reasonable choice because not all inferior breaks fail. Many inferior breaks settle with vitrectomy and gas or oil. We'll just go in further sub-analysis. Now, these are the patients with inferior breaks. There were 20 in the gas group and 2 in the oil group. Now, in gas group of the 20, 17 were attached and 3 were detached. Whereas in oil group, in my experience, both the patients were detached. Now, putting additional buckle. In 18 patients, I had not put buckle, but still 15 were attached and only 3 were detached. And in 4 patients, I had put buckle along with vitrectomy and internal tamponade. Only 2 were attached and 2 were detached. So I believe that putting buckle may not give a great success in inferior breaks. It's primarily also because of PVR process that the retina detaches. So to summarize, buckle or oil has no advantage over gas tamponade in inferior breaks. That's what I would probably feel. Now, if we classify by PVR all these 100 cases, we had 83 cases with PVR B and 9 with PVR C and 2 with PVR D and 6 with long-standing detachment. And what we did with gas and oil, we'll just go through that. In PVR B, the tamponade of choice was gas because 78 were gas and 5 were oil-filled eye. Of the 5 oil-filled eye, 50% had detached, 2 were attached, and 3 were detached. Whereas with the gas fill of 78, almost 80% were attached, 62, and detached was 16. In PVRC, we had about 9 eyes, and of which in 4 I had used gas and all 4 were attached. I'd used oil in 5 cases, 50% were attached and 50% were detached, 2 and 3 were the figure. So here both places we have 50% with oil, whereas with gas, the ratio is more. Now in PVRD, I'd used oil only and both cases were attached. In long-standing detachment, where I had done vitrectomy as a primary procedure, the 6 patients with gas were attached and 2 were detached, and with oil, both 2 patients were attached. So probably long-standing detachment, our results were better with oil, though the numbers are small. Now, this is an interesting observation I got to know from my series that 32 eyes of phakic eyes and vitrectomy was successful in 80% of cases and 20% there was failure. And pseudophakic eyes also 75% were attached and 25% were detached. So probably the results were not bad in phakic eyes, they were quite good. So I think vitrectomy can be considered as a primary surgery even for phakic eyes. Probably I have not included patients less than 20 or 25 years of age. So probably all these patients would be 40 or 40 plus or 35 or 40 plus. Now let's go through some of the cases. Now this was a superior giant tear which got attached with vitrectomy with C3F8 gas. No oil was used. This was inferior giant tear. Again got attached with vitrectomy with gas C3F8 and no buccal or no oil was used. Now this is one of the recent patient with a giant tear and this is with gas C3F8 and you can see that the giant tear has been very well opposed and you can see a good laser mark. So in fact, I don't do a belt buckle for giant tear and normally I don't do belt buckle now as a routine. Now this was the inferior horseshoe tear which had undergone vitrectomy with gas. It failed. I had done re-vitrectomy with oil, but it still failed. Probably a buckle would have been helpful in this patient because the recurrent detachment was because of the breaks at the vitreous base. Now this was a case of PVR-C1 again got attached with vitrectomy with C3F8, only one surgery. Now this was a case of anterior PVR and PVR D3. This patient I had done lensectomy with vitrectomy, oil and buccal and this got attached. Now this is a patient who was very unfortunate. This was a patient where I thought pneumoretinopexy would help. I did pneumoretinopexy. The retina got settled. He recovered 624 vision. But however, after 3 weeks, he got detachment again. And with the same break which had reopened, which was at upper nasal quadrant. So I did vitrectomy 23 gauge with C3F8. Unfortunately, on 8th or 9th day, he had hyphema, and I thought patient had bleeding disorder. Retina was attached with C3F8 on sonography. We couldn't pick up detachment for almost 5 weeks following surgery because C3F8 would remain in eye. And when I operated again, he had a large tear, which was probably a cause of hyphema and vitreous hemorrhage. And this patient did not do well with revitrectomy and lensectomy and silicone oil and buccal. So to summarize, microincisional vitreous surgery with gas tamponade is most rewarding procedure for primary rhegmatogenous retinal detachment. For inferior breaks, vitrectomy with gas work equally well. Use of oil is good for certain selected patients. Phakic eye do quite well with vitrectomy, just like pseudophakic eyes. And PVR is the most important contributing factor for surgical failures. The next common being in my study has been iatrogenic complication during vitreous surgery, that you create breaks or something that could be associated with worse results. Thank you for your patient hearing.